Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Welcome everyone back to another episode. Today I'm with Dr. Anish Gupta. He is an oral and maxillofacial surgeon practicing in Michigan. Anish, thanks for joining us on the podcast today.
Yeah, thank you so much for having me.
Yeah, we got some good feedback about our last episode with AI and the applications in oral surgery. So thanks for doing that. It was fantastic.
Absolutely.
Today we want to talk just a little bit about kind of PRF and some of the ways that can enhance some of the treatments we do. So where would you start us off on that topic of PRF?
So, I don't know, I like to think of the first time I used it. So I was on my anesthesia rotation. I did an anesthesia year in Indiana, and I remember the circulating nurse was like, "You need to draw some blood." And I'm like, and this was an orthopedic case, and I'm like, "Why do I need to draw some blood?" He's like, "I don't know." The circulator was pretty annoyed that this orthopedic surgeon, needed to draw some blood to create PRP. So we're talking about platelet concentrates. We probably need to talk about platelet-rich plasma as well as the first generation. So we drew some blood. They had the centrifuge. They put some bovine thrombin in it, and they basically created this, this jelly was what I used to when I first saw it. That's what I thought. And then they sprinkled it a lot, this total joint that they were doing. And I was like, oh, that seems pretty cool. What is that? And then in oral surgery residency itself, we used it platelet-rich plasma as well. They had it in the ORs for us. So we use it on some of our big bone grafting cases when we were like harvesting a hip or something like that. And yeah, it was kind of where I first used that or first saw it. What about you? Did you guys use that in residency?
Not really. I mean, it was something kind of just later on that I, heard about and then started learning about and then just doing myself. But I mean, a lot of good applications. Where do you find it to be most useful in your practice?
And so when I moved back to Michigan, I was associating for somebody else, and he was actually the one who was like, "Hey, I think we should start doing this." He ended up buying a centrifuge. By that time, we're, looking at that second generation platelet-rich fibrin. And just, I guess, to make the distinction, how I learned it is that in the OR to make platelet-rich plasma, we would use these collection tubes that have anticoagulants in it. And if I need this blood to get sticky or to clot, to get these platelets to degranulate, now I need to add some kind of, clotting mechanism. So we're adding bovine thrombin to it. And so the second generation, I'm not the strongest historian about it, but essentially somebody's like, why do we even need to, do that step where we have anticoagulants and then add coagulants? And so now we've got these tubes that don't have that in there, and we allow, the blood to clot naturally and let, the platelets do their thing and, release our growth factors and, get sticky and things like that. And so, now we can draw blood, let it naturally clot, spin it down, use the concentrated stuff that we want to use. And so anyways, long story to say that I started doing that. We tried it on ourselves first. I initially used it for extraction sockets, and then eventually kind of morphed it into my day-to-day use on it is going to be after we do thirds, we are, taking our, platelet plug and we're putting it in 17 and 32 kind of as a, socket plug for us. What about you? What are you using it for?
Yeah, we do basically what you just described, 17 and 32, kind of a socket plug to enhance clot formation, improve healing. Thought is less chance of dry socket, things like that. And then the other big application is just basically we have a protocol where we spin it for a short period of time, usually 1 to 2 minutes before the clot forms completely, but it separates the platelets out from the whole blood. And then when it's liquid form, you can kind of remove that top layer, inject it into the bone graft, let it sit there, congeal, and then it makes the sticky bone. And that I feel like just makes the graft much more manipulatable. You can put it where you want it, it stays where you want it, and then it's also releasing those good growth factors and just see it healing better.
Yeah, absolutely. So I think it's probably fair to say I like to give balanced opinions on things. So, I mean, PRF, a lot of people make it out to be this like magical fix-all that's going to heal everything solution. I think most people would argue that it doesn't, that it doesn't do any of that, but it does help, obviously, and that's why I like to use it. So I don't want to create in people's minds that, hey, this is going to be this magical solution that will, solve all your problems with wound healing and
Yeah,
completely prevent dry socket and stuff like that. But at the same time, I think, like you said, at the very least, even in bone grafting, sticky bone's a pretty nice thing to work with as opposed to dealing with. I like to think of it as wet sand, if it's just using, particulate bone and putting it in a socket. But now I can do a sinus lift and maybe I've got a micro perforation that I didn't see and I don't have to worry about graft going all over somebody's maxillary sinus, or if I've got like a big GBR, and of course we're going to put a membrane in there or whatever we're going to do, but at the same time also it's so much easier handling that a membrane is going to sit over it much nicer. We've got much more stability and rigidity. And when it comes to bone grafting, we need that stability so that that bone graft can consolidate. So, no, definitely advantageous there as well.
for sure. Yeah, I love that application of the sinus graft. When we're doing it as a graft, we'll usually do, if it's just like a single tooth or single sinus lift, we do two tubes or sometimes four, but we'll take out, do the short spin, take that out, put it in the graft, and then another tube that's a little bit longer spin or let it congeal there. And then we take the clot out and flatten it and use that as a membrane on top of the graft. I'm sure you're doing similar things, but maybe can you walk us through like your standard, let's say, I don't know, extraction of a 30 that's planned for bone graft and membrane? Like, how does that look for your team?
Yeah, so let's say we're extracted to number 30, ridge preservation, and I'm using, some kind of allograft, corticocancellous, particulate. We'll get the patient back. We'll go ahead. I usually like to numb first, and while that numbing is working, if it's a local case, then I want to have one of my team members, because we've got all our assistants kind of phlebotomy trained to draw blood. They'll go ahead and draw blood for a single tooth site. We're going to draw two tubes. I hear you saying that you like to do like a short spin to kind of get the liquid PRF, and then a longer spin probably made it coagulate to get a like a membrane that you're going to use. We use essentially two different types of tubes. We essentially have a hydrophobic tube, which will stay liquid longer, and then we'll have like we call it a blue top tube, and then we have a red top tube, which is not the hydrophobic thing, which will be more prone to clotting, so that we can make the membrane that when you Google PRF and look at what people, these slugs that people are pulling out, that's the more traditional slug, or the snot, even some people call it. So we'll have two tubes, one for our membrane and then one for our kind of liquid. The liquid one we go ahead and put into our bone graft, and then we actually cut up a little bit of that, the slug looking one, to actually create a nucleus to make that sticky bone, because I do find that it gets, I don't know if you've ever done it and you're like, oh, this bone is still kind of like meal or mush and it's not actually consolidating. And so by adding some of those remnants of the red top one, that's more of a slug, we get that to have that nuclearization point, and then it does clot up a little bit better for us. And so now we have got this kind of moldable patty. I think of it kind of like, my daughter has like kinetic sand, and that's what I think about it as, is like, hey, we can kind of mold this and put this in. Anyways, that's all happening on the side, with our 8-minute spin. We're gonna go ahead and do our extraction, cure out our socket, make sure there's no, other foreign bodies, anything else in there, flush everything out, and then we're gonna go ahead and essentially pack the socket with that. A lot of times I'm still going to use like a collagen membrane, because I've found that if I use just a PRF membrane, I'm going to still have soft tissue ingrowth into that. So for ridge preservations, I'm still going to use some kind of longer standing barrier. I think a PRF membrane, if I remember correctly, is only going to be around for, anywhere from like a week to 2 weeks. And so if I don't want soft tissue ingrowth into my graft, I will put another membrane there. But I will still put that PRF membrane over it, because I do find that that does create a lot better soft tissue growth. And I think it's a pretty fair assessment to say in the literature as well that PRF does not aid in like bone growth or bone turnover or bone, consolidation, or at least it's controversial. Most people use PRF for handling, but when it comes to soft tissue, I think that's pretty unequivocal that, hey, PRF will aid in, soft tissue coverage, soft tissue growth. faster healing times, which is again also why we like to use it for third molar sites.
Very nice. Yeah, that's awesome. I just think that the handling itself is just so much nicer. And if for some reason, like our centrifuge doesn't work that day, or so there's some problem where we can't do it, and we have to go back to non-sticky bone for a day or a procedure. I mean, it's just such a stark contrast of um, manipulating it, putting it in, it's squishing all over. And two, I feel like there's just more calls like after the fact, like more post-op complaints of, oh, this stuff's coming out, or patients are, worried. And I don't get that much. If you make a really good sticky bone that stays there and it's nice and clean and tight, it just very few people call and say things are coming out or it's feeling loose or I don't know. It's just, or there's
Yeah.
pain. It's just kind of weird.
That's so funny. Yeah, I don't think I don't even know if I remember that because I haven't had those phone calls in so long. But you're right. When we used to do traditional particulate bone and you've soaked it in, normal saline and you've like tucked everything away nicely with the membrane, but something happens. Obviously, mouths are very pliable areas. And so they're talking, they're eating, and all of a sudden they're like, you get that phone call. They're like, hey, I feel like there's bits of sand in my mouth, or I feel like there's bits of like
Mm.
black pepper, like I've got these things on my tongue. Should I be concerned or what do I need to do? And most people who are calling are pretty like panicked, like they spent a lot of time and money on this bone graft and they really want it to
Yeah.
work because they've had a friend or a family member whose bone graft failed. I feel like I've heard that so many times.
Hmm.
And now they're like, something's not right because, these particles. I used to warn people too. I remember at some point I was like trying to preempt those phone calls. I'm like, hey, you might get 3 pieces, 17 pieces of this stuff, but don't worry, we put in 1,000 pieces. And so when these little bits of sand come out, you don't have to worry about it. But thankfully, I don't even have to do that kind of counseling anymore because it's pretty the way we do things now is pretty clear cut. We don't get a lot of, extrusion of graft. I think I've also changed a lot of my, closure techniques. I'm doing a lot more watertight and primary closures for my big grafts now too. And so we also don't see it because of that. But it is absolutely nice not to have to do that. Explain to people or have, worried patients afterwards.
And cool that you're using the different types of tubes. I mean, for simplicity's sake, we usually just do two red tops and we spin it for 90 seconds to 2 minutes. But that's like the key for us is you have to, the assistant usually does, and they have to be paying attention to like get it out right at 90 seconds or 2 minutes. If you wait 3 minutes, then the clot's formed and then they just pour like the top PPP layer on, and that doesn't really congeal. Or the old way was like they used to chop up the clot once it had formed and kind of put it in the graft, and it just kind of still mushes around. It doesn't really make that sticky bone where we want it, where you pour in the liquid top layer, it congeals around the whole graft, and then you can almost take a pickup and like grab the whole
Absolutely.
graft, and like not a single flake of graft is lost. It's just all there. It's just incredible when that
Yeah.
happens.
You want it to be like Jello with impregnated graft. I mean, that's the
Yeah.
ideal scenario that you want. Well, you're right. I've had every scenario that you just described as well, where you've got like that platelet poor layer goes in, and now it's just like liquid with some graft in it. And then you're like, okay, we'll just take the PRF plug that we have, chop it up into really nice pieces, and kind of like mash it together. Like you're almost like pushing in the graft into those things. And that reminds me of like those like gummy nerds, if you've ever had those. You've got these like squishy candies with just like bone sticking on the outside of it. And like, yeah, I guess it's better than just graft on its own, but it's still the same. Still got the same problems. The handling isn't great. But yeah, it is magical. And I think like even the assistants when they're making it get so excited about it now that when it works and they're just like take the little cotton forceps and they pick the whole thing up to like show you like, hey, look what I made today. I think it does add value to them too. I do also think that the whole PRF protocol that we have and stuff has made our assistants really, proud of what they do because not everybody's doing it or they worked at a GP office before and now
Mhm.
they're doing this and they're like, I'm drawing blood, like I'm a healthcare worker and now I'm doing this and I have this, skill that I didn't have before. And I think that's so valuable to have that as part of your team where people feel valued and are doing something that they've, gained new skills and respect for.
And I've also found that patients, they understand it and it kind of makes sense to them to like take something out of your own body that it helps with the healing process and use that in graft that it would enhance it, right? To use your own platelets, and you kind of talk about how it takes days for your body to get the platelets, like if you were to skin your knee or something and make a scab. We can kind of speed that up by putting the platelets directly in there. I don't know. So things like that just make more sense. And patients, oh yeah, that's really cool, and they're, yeah, that's really great that you're doing that. And I feel like there's just more of a sense of like, wow, you guys are really trying to use technology and my own, body here to really help the healing process. And I think people appreciate that.
Oh, absolutely, right. I think you've probably heard this when you're doing thirds and maybe you're going through your, third molar consultation and you're like, oh, this is what we're gonna do. And then like moms and dads, his eyes will get big and they're like, oh man, things have gotten so much better since when I got my wisdom teeth taken out. And they're like,
Mm.
appreciative, like you just described, of hey, things are changing and you are doing the best thing for my son or daughter. I have a nice evolution story from that too, because I used to start it. We didn't used to charge for it. I got my own practice. We did end up creating a system where I was using Exparel, which is liposomal bupivacaine,
Yeah.
and platelet-rich fibrin. We kind of bundled everything together, and it's not, a covered benefit for most people. And so, we charged $300 for 17 and 32 for both sites for Exparel. And it wasn't like a profit generating thing. It was just something that, hey, I want to do this. I think it adds value. And my question that I had was like, how many third molar cases are going to accept this? I think we all have this idea that if something's not covered by insurance, our patients aren't going to, buy into that. And so I tracked it for 8 months. And I was like, okay, if I'm gonna give the same consultation to all these patients, I want to see what our acceptance rate was. And I was surprised. It was about 80%. So
Wow.
80% of, moms and dads and, people who are getting the third molars out would be like, oh yeah, that sounds great. You're gonna do something that's gonna, have prolonged, local anesthesia, and so my kid's not gonna need, narcotics. Or hey, you're saying that people will be able to get back to work and school, a little bit faster. People are like really worried about dry socket. Every single person who comes in knows somebody who had a, dry socket horror story, and we're like, what, our dry socket rate has really dropped since we started doing this. And so, people would buy in and would pay for it out of pocket. So I thought that was really surprising. And then since then, I've found value in it. I get less, phone calls for complications. We get less issues with pain. We get less infection rates. And so I just made it so that we just do it for everybody. And then we've since then also have gone, non-par with insurances. And so now that we get fair fees for, everything, I don't worry about having a cost associated with that. And that's just kind of a personal philosophy. So I wouldn't say everybody needs to, do something that way. I believe in it so much that we don't charge our patients for it.
Nice.
Yeah.
Yeah, that's a great thing to offer. How about your third molar technique there? Is there any difference in the spin or the way you use it compared to a bone graft?
Slightly, yeah. So I feel like as oral surgeons, we're pretty dogmatic about thirds. I do 1, 32, 16, 17. That's just the way I like to do things. And so I'm taking out one. Hopefully by that time the spin is almost done. Because we draw the blood at the very beginning. We get the IV, draw blood at the same time. And so while the team is still getting everybody hooked up and we're doing our timeout and stuff like that, it's spinning in the background. So by the time I'm done with one, usually it'll be ready. I'm just doing a red top tube, and we'll do two red top tubes, one for site 17, one for site 32. We do our normal spin, which is, I believe, 700 RCF at 8 minutes. And it's really important that you get not just the platelet yellow plasma plug, but also a little bit of the red, because that's where a lot of the the cellular stuff, when you're talking about leukocytes, or a lot of the growth factors are there too. I'm sure there's some study which proves this to me, but I remember being taught that we want to make sure we get a little bit of that buffy layer. So we take that and we just kind of go ahead and plug the socket with it. Again, evolution for me is I used to do a gel foam over the top, because it's a little hard to manipulate that sometimes. And I was like, okay, if I've got a gel foam layer on top of it, it's going to sit a little bit better in the socket. And I did track my cases for that as well during those 8 months. And I did have improvement in my dry socket infection callback rates, but not nearly as significant as I thought it was. I stopped doing the gel foam, and I did start seeing that much more. I bet I'm sure if I did a statistical analysis, we'd find it to be much more significant. But um, after we just did the clot with no gel foam, I can tell you that our dry socket bin has been unused for a pretty long time.
So it's extract 32. Do you irrigate? Is there anything that
Yeah.
happens there between taking or putting the clot in and do you suture? Do you not suture? How does that
Yeah.
work?
So yeah, 32 is out. I do pretty much curette just about everything, make sure there's no loose bone. I do flush it out. I usually use just like a 10 cc syringe, so I'm not doing, significant flushing or multiple flushes. And then I put my platelet concentrate, I put my PRF plug in there, and I usually just do one singular suture over it. If it is a fully extracted, or sorry, fully erupted 17 or 32, I do put a figure of 8 over it to kind of hold that clot in a little bit better. But most of my impacted teeth, I just put like one suture to reapproximate tissue, and that usually holds things in pretty well. And definitely for when we see follow-ups too, again, I think our follow-up rate for thirds with complications have definitely, come down. But when I do see people come back, we tend to see a lot more mucosalization when I'm flushing a site out because I'm worried about food debris or something else, which thankfully doesn't happen often. I'm not seeing a lot of like PRF clot or anything like that come out. It's mostly, vegetative stuff if there is something stuck in there. So yeah, I think it does last. And I definitely feel like there's better tissue formation after we do it.
I mean, another question would be just in regards to like post-op prescriptions with PRF, like specifically, do you like prescribe chlorhexidine? Do you not want them rinsing with things? Have you noticed anything there with like doing rinses that could potentially dilute it or wash it out? Or I mean, both with graft and wisdom teeth.
Yeah, good question. And that's actually just been a recent change for us. We stopped prescribing So I used to prescribe chlorhexidine for just about everybody, third molars, single tooth extraction, bone grafting, implants. We did stop chlorhexidine for implants probably about 2.5 or 3 years ago. There's like the data that's, the in vitro stuff in dishes where chlorhexidine is like, is inhibitive to fibroblasts and, healing and stuff like that. Obviously, there's plenty of data out there that shows the benefits of chlorhexidine, so I'm not trying to demonize it by any means, but we stopped chlorhexidine for implants about 3 years ago. And then actually just about 4 or 5 months ago, earlier this year, we stopped chlorhexidine for everything else as well. We'll still prescribe it on a, prolonged, delayed healing case or somebody with autoimmune issues. But it's not routine like it used to be. One of the things we learned in the last course that we took is that PRF will degrade a little bit faster with chlorhexidine, and so we did stop it for thirds regularly as well. Now that we're kind of all in on PRF, and so yeah, so we actually stopped chlorhexidine for third molars, for bone grafting, and for a lot of things. We have incorporated StellaLife a lot more, if you've heard of that, or
Hmm.
I know a lot of the big institutes are using a lot of StellaLife, and I'm not here to push it or plug it, but we have found that it does help with bruising, with post-op pain, and then even some cases that I've just tried it out for pathology stuff like aptus ulcers or lichen planus. We've definitely seen good recovery. I can't tell you if it's faster recovery or not, but yeah, I've drank the juice on the StellaLife stuff, and so we've incorporated that for a lot of our third molars as well. So, anyways, short answer to your question: StellaLife over chlorhexidine for a lot of our PRF cases.
And is the StellaLife just are you able just to prescribe that as usual, or do you supply that, or how does that work?
Yeah, so I mean, we have to stock it on the shelves, and then for most cases that we're doing, that's again, it's also incorporated into our fee. And so, yeah, so for a lot of third molar cases, patients are getting the StellaLife and consulted on how to use it. So we're doing the StellaLife kit. That's kind of like the 333. There's a rinse, a gel, a mouthwash, and they start at usually 3 days. They use it for 3 days, 3 times a day. Yeah, and so again, we're seeing pretty good results with it. I like it. Patients seem to like it. So for now, we're going to continue that.
Any other applications of PRF or PRP that you would use in your practice or would
Yeah, let's run
recommend?
through some of the things that I've had challenges with. I think the first one is you've got this, hey, you're like, hey, you want to have that amazing sticky bone where you can just pick it up with a cotton forceps and you can put it and handle it wherever you want to go. What can you do if that doesn't happen? So you're just like, this is just water on here. And you mentioned like somebody's got to be really vigilant to make sure it's only 2 minutes spinning and not 3 minutes because then it's gonna, clot up. And so a couple of things that we've incorporated, and we don't use this super often because we do have a system where people are, vigilant. So if we got a case and if you got just a red top and it's not a hydrophobic tube and you want it to sit around liquid for longer, you can spin it your normal spins And then we've got a cooler. It's just a little ice. It's like almost like a little ice bath. I can't remember the exact temperature that it keeps it in, but you can leave it in there and it will stay liquid longer. And then the reverse of that is, hey, do you want to make something jelly up faster? So let's say you've got that more of the platelet poor plasma, or maybe the spin didn't go the way you wanted to, or maybe the patient just doesn't have the biology that's necessary for this to happen. And so you'll get the liquid stuff, we'll mix it with our bone, and we have an incubator. So we'll go, I mean, it's just from Amazon. It's like a reptile incubator, if I'm not mistaken. It'd be what you would use to like hatch lizards and snakes or chickens. And so we have it. And obviously we don't do any of that stuff, but it's sitting in the corner there, and we can go ahead and put our sticky bone in there, and that will almost for sure guarantee that it will, solidify into that sticky bone that you could use. So if you've got like a big GBR case or a big sinus lift where things are taking a little bit longer, we'll use that, and then we'll by the end of it we'll be guaranteed to have that handling that we want. So again, fun, relatively cheap adjuncts that can aid into your PRF. I always get questions about cost for PRF. So we'll have even like GP offices that are more surgically focused, and they're like, well, we want to do PRF, we want to incorporate it. In the state of Michigan, it's not very difficult to be somebody who can draw blood. The Michigan Board of Dentistry, it's kind of a gray area, so we usually recommend people to get some kind of phlebotomy training for that, for their assistants if they want to do that. But like a centrifuge, I mean, I've seen centrifuges as cheap as $100. Not that I'm advocating for those ones, and then even like a really nice one, is going to be like 2 grand. So I like the ones that have got protocols already built in because somebody's already done the spin, somebody's already taken labs and CBCs on these things and looked at it, in a laboratory to be like, hey, this is the layer, and this is, we know these spins will get you, how much, platelet-rich, fibrin, and that's got, leukocytes in it. It's got your, platelets have degranulated, and you've got your growth factor. So I personally like a system that's been validated. But I think generally speaking, at like $2,000 for something that I use every single day, it's probably one of my most used pieces of equipment, minus my sterilizer. And so it gets a lot of value for that $2,000. And then an incubator is on the order of $100. Some of the cooling stuff we have is on the order of like um, I don't know. It's less than $100. There's none of the stuff is super expensive for the value that we get for it. Sorry, I went off on a tangent there. But anyways, I think the cost is very applicable, and I think there are these adjuncts that you can use to make things a little bit easier if you need more reliable or consistent handling for certain things.
Yeah, nice. I don't, I mean, those are my main applications, but I've heard people, doing injections of PRP or things like that into, like, for example, masseter muscles with people that have, like, I don't know, TMJ issues. I don't have much experience doing that. I don't know if you've done anything for myofascial pain or anything other than the standard usages that we've used. But yeah, I mean, I'm sure there's all sorts of applications like you're mentioning. Orthopedics use it in joints and all these things, and so there's got to be some of that. But I think the main workhorse is extraction sites, um, and certainly bone grafting, sinus lifts, things like that.
I haven't done any of the TMJ stuff or like the masseter and the myofascial stuff. There's definitely lit out there. I haven't. I like to pay attention to all the JOMS articles that come out, but people are injecting PRF and comparing it to like hyaluronic acid, in
Mhm.
joints, and the data is optimistic. It says that it's helpful and things like that. The orthopods are definitely using it for knee injections and spine injections and things like that with what they say is good results. I haven't looked at that literature, in depth, so I can't speak on it too much, but they always talk about the positives of it as well. I haven't seen any injections in the masseters or anything like that. That'd be curious to see. But I do see a lot of people using it for facial aesthetics. I don't know if you do any aesthetics
Yeah.
in your practice at all. But just like you mentioned that people are like, hey, it intuitively makes sense for a lot of patients because you're like, hey, I'm not injecting fillers or these other things and that are chemically oriented. Like this is just my own stuff. And so I think there's some value in that. And definitely the other side of that too is like for like hair regeneration. I think there's a big market for that as well. I personally don't do any of that stuff. It's just not what I find enjoyable. And there's plenty of people around me who do a much better job of it. So we send patients there. But again, if that's something that you'd want to get into, there's definitely, niches for all of that.
Or the surgeon maybe who hasn't done this and wants to get into it, what would you recommend as far as learning the process?
So, I mean, as with anything, I like formal training for anything. So that's probably what I'm going to recommend to anybody is that, hey, there are PRF courses, available. I believe Amos puts some on. Rick Myron is a big, he's one of the big researchers for it. He'll tell you that he's got the most publications on it, and he does courses, around the country on that. So there's probably one near you at some point during the year. I think as oral surgeons, we've got good training in starting IVs and anesthesia and drawing blood, and so that shouldn't be a new skill for us as clinicians. I think if you're another type of specialist or general practitioner who hasn't had that, then I would probably try to get formally trained in that as well, or get your team trained in that. And phlebotomy is a skill that's needed around the country, and most hospital systems can point you in the right direction for where you need to go for that. I think the easiest thing to do is also just get a centrifuge, get some tubing, and practice on your team or have your team practice on you, and then actually spin it down. And I think you do it, regularly. I think you would attest that it's not super difficult to actually do this from beginning to end. And so I think there's a lot of value in just trying it out and seeing how it works. And I
Yeah.
think you'll be able to find out that hey, this is not a super difficult thing to do. The risks are pretty low for it too. You're not going to get an allergic reaction, with this. But yeah, I think trying things out is as long as you again buy the right tubes and the right equipment, things can move pretty smoothly.
I would add that a lot of these courses too, I mean, it is nice to go and do things and have hands-on in person, but a lot is online. I know Richard Myron did the whole thing online course, and you can literally just watch it from your computer. I know the Picos Institute like partnered with him, and they have an online course that he does. So there's tons of very easily accessible. I mean, I'm pretty sure even just most of the stuff is free on YouTube. You can just watch Richard Myron's whole thing there.
Right,
Yeah,
he does have really good videos, and we did use that to train the team as well. That's a great point.
yeah, great resource there. I mean, I'm sure too there's colleagues who are doing it around your area would be happy to have you come watch that type of a thing.
Absolutely.
But yeah, I think pretty low cost and low kind of I guess educational barrier to get through to start doing it. It's pretty simple, easy, not too many supplies. I think it's a pretty great thing all around. Good stuff. I
Yeah.
appreciate you kind of talking about this and sharing your experience and some of the pearls that you've gained with it. That's really helpful.
Yeah, thank you. Can I add two more things that I think
Yeah.
are fun future things for PRF? I haven't done this yet, but I do have a colleague, Colorado, you might know him, Austin Ivy, and I know he has talked about adding things to his PRF. The one he mentioned to me was like Myers solution. So essentially vitamins and other things into or amino acids into his PRF specifically with bone grafting to get better results. I think that's a fun thing that I would like to explore in the next year or so. Another aspect that I also learned at the PICOS course was like albumin PRF or extended PRF. One of my big gripes with the whole PRF thing is that it's like alphabet soup. Everybody's got their different
Mm.
names for everything, and it's always just like a bunch of letters. So extended PRF. So I told you I've got an incubator, but I've also got an oven. And we don't do this super often, but if we're doing like a big case, I've definitely used it for like zygomatic implants where I want some coverage. But you essentially make PRF the same way you would, and then you actually put it in an oven. So you just drop the platelet poor plasma, so none of my growth factors or cellular stuff. Put that in the oven, and it'll actually cook, right? And so there's albumin in there, and so it will literally turn into like an egg white. just like you're
Mm.
cooking an egg. And then we have a little thing and you can like mix the cellular stuff in with that once it's cooled down so you don't kill your cells. But it essentially creates like this long-standing if you talk about like handling and everything like that, but it makes like a extended membrane is how I like to think of it. And I think that if you've injected under rats and they've got studies for it, it sticks around for like 4 to 6 months, which is like a really
Wow.
nice thing. So like you've got this, membrane that is going to stay around for a lot longer. The downside of that, of course, is that it takes 4 to 6 months for it to like release those growth factors as well. And so it's not going to be something that's going to
Mm.
like improve healing or have better soft tissue coverage. I think a better application of that would be facial aesthetics where you want to like plump up somebody's cheekbones or something like that. You can go ahead and, inject that and, get a little bit of filler like, PRF in those areas. But anyways, I've used it for if I've got a big GBR and I want to just make sure I've got good soft tissue coverage or good coverage despite having primary closure, like I always worry about a dehiscence or something. And definitely over like zygomatic implants where you've got like a big portion of that implant that's uncovered and you don't want to end up having like an oral antral communication.
Nice. Yeah, that's a great thing to know about and mention. Austin Ivy works in our area, so maybe we could get him on the podcast as well at some point to talk about that. That's pretty cool.
Yeah, he's always got the most innovative stuff. As when I talk to colleagues, he rarely fails to inspire me or like surprise me with stuff. He's always thinking.
Cool. Fantastic. And then one last question. You mentioned Exparel. Are you still doing that? And do you have any tips or pearls on using that?
Yeah, so Exparel, I use it primarily for third molars and for full arch. So do I think it's a wonder drug? Nope. I think it adds value, but I don't think it's like a magical, hey, you're not going to have pain afterwards. So Exparel, for those who don't know, it's liposomal bupivacaine. If you remember from, like biochem physio, like it's a phospholipid bilayer or a micelle essentially the Marcaine local anesthetic that we always use is going to be in these little, I think of them as little fat cells, and then you inject them and they kind of slowly open up over time. If I remember correctly, the manufacturer says 5 days is how long it takes, but my experience has been usually around 3 days is when patients tell me like, oh, it wore off by that time. I do use it regularly for third molars, and so one of the things is that because of PKAs, it can't mix with other local anesthetics because those little liposomes will pop. So you can't do lidocaine and then put Exparel right after that. So it has to be just bupivacaine. And so, for example, I do have to change my numbing technique and I can't do a long buccal block with lidocaine or articaine. I'd have to use Marcaine for that. And then the other thing about it is if you did use the lidocaine or septicaine, you do have to wait 20 minutes before you can, put that in. So the timing of certain things, if you wanted to keep doing your local anesthesia the same way you normally do, you'd have to wait 20 minutes, which might sound like a little bit too much if you're moving fast. Anyways,
Mhm.
I do use it. I mainly put it in like long buccal region for it because it doesn't infiltrate. You kind of have to do like an inject and draw out method for that as well in multiple locations. So you kind of want to put that local anesthesia wherever you want it to work, which is great because you're not blocking with it. Nobody's going to have a numb lip for 3 days. Nobody's going to have a numb tongue for 3 days. It's arguably a complication, but I haven't seen it in the 4 years that I've been using it. And then, yeah, so that's the kind of thing. It is a fun observation that when patients do call about pain, because I usually tell patients, hey, if it should get better every day, and if all of a sudden your pain goes up, please give us a call. We tend to get phone calls on day 4. So what I think is happening is that patients are having relatively good comfort, and then all of a sudden the local anesthesia has finally worn off, the bupivacaine, the Exparel has worn off, and then on day 4 they'll be like, it has jumped up. Most of the times they call, it's not like, a level 3 to a level 9. It's mostly like, oh yeah, it's like a level 3 to like a level 4 or level 5. And we're like, oh, okay, don't worry about that. It's just, continue to do the things you're normally doing, keep things clean. And so do I think it adds value? We've, been opioid free now for almost 5 years. And so we don't routinely prescribe opioids for post-op pain for third molars. We do our alternating, acetaminophen, ibuprofen. And then with Exparel, we tend not to have to do it. And yeah, it's one of the nice things about that we don't have to deal with those other issues with opioids that a lot of people see.
Great thing to offer as well. We do that as well, at least offer Exparel injections and same exact experience. Usually it gives you relief those first 3 to 4 days, and then kind of getting more calls day 4 and 5 at times. But yeah, such a great thing, I think, to have that discussion about, hey, we're trying to avoid the use of opiates and exposure, especially if you're a young teenager. And then I think it's also great for there's a group of patients, who are just allergic to everything, allergic to
Yeah.
ibuprofen, allergic to, opiates, everything. And so to be able to give them some adjunct that can knock the pain down is helpful.
Yeah, absolutely. And I think it's funny too. I mean, we definitely still have patients who are like flabbergasted that, oh, you're not going to give me, the Norco, you're not going to give me the Tylenol 3, and then we can say, hey, but we're going to, do this for you. I do use it for full arch, and I do find it to be a little bit more valuable again, this is anecdotal experience for me, is that I find it more valuable in the maxilla than the mandible. But I've had at least, two patients who have told me like, yeah, I have zero pain afterwards, which is even as saying it out loud, I'm pretty skeptical to hear that after like a full arch. But like after the first one, and I heard the second time, I was like, maybe there is, some advantage, to it. And again, we also have tough patients who maybe, aren't whiners. But I think they're obviously comfortable enough where they're like, oh, I thought I was going to be, in a world of hurt and be like really, really, and they do have swelling, but they're just like, yeah, it's not as, bad as I thought it was going to be. And so I do find it, I find Exparel very valuable in the maxilla for full arch cases there.
Oh, for sure. Yeah, I've learned to be careful too with my description of it. I definitely avoid saying you're going to be pain free because, and I say, hey, we're injecting it like you say, kind of in the cheek area, and it should numb where we make the incision, and that area is usually where the pain comes from, but we're not numbing your whole jaw, and so that deeper bone pain can be there, type of a thing. But it helps, that type of thing. I think at first there was too much um rhetoric from myself and assistants and staff. Oh, you're going to be pain free, and then when they do feel that bone pain, they're like, what, I paid extra or whatever it was for this, and they're can be more upset because it's like, oh, you said I was pain free and now I'm not. So I think just being cautious and careful with what you say, very realistic, terms is good. So you're not over promising and under delivering.
I've lived that same experience and mistake that you're talking about as well. And like, oh, you're going to be able to go back to work tomorrow because you're going to be feeling so good. And like these, yeah, like you said, this over promising. And absolutely, I think I've tempered expectations and given more, realistic of like, hey, you won't be, pain free, but with Tylenol and Motrin, you're going to be much more, functional, and you're going to be much more functional faster too.
Yes, for sure.
And what you said about, for your like third molar consults, and the people are intuitive about thinking that, oh, PRF sounds really good. I also get that during consultations when we talk about Exparel and, hey, we're not going to prescribe any narcotics for your kid. That really, really resonates, for that 16 to 19 demo and the moms and dads who are coming in with them. And you're like, okay, great. I'm really worried about my kid going off to college and, being away from us and being exposed to some of these things. And we're like, hey, at least we're not going to expose them to not. Parents really love the idea that, hey, we're not going to be doing some of that stuff. And so
Yes.
they're more apt to like trust you and go along with the treatment, and just generally, happier about the consultation
Yeah.
and the outcomes.
Oh yeah, 100%. Yeah, I think both of those things, PRF and Exparel, just kind of sends that message that, hey, we really care about, the healing process. We're willing to make um, like changes and kind of fine tune things enough that we take the edge off. And in maybe it's not a huge change, but there's some degree of improvement in the healing process. I think that's what most patients are anxious about. I mean, they're anxious about the numbing shot, but then after like the pain of being in the chair, they're anxious about the pain over the next few
Yeah.
days or the healing process of what's it going to look like, and anything like PRF or Exparel that's gonna make that a better experience. I think people a lot of people will appreciate that. There's always going to be some that are just like, heck no, I did this 20 years ago this way, and that's how I want it. Let's
Yeah.
stick to the good old stuff, and that's fine.
Yeah,
So,
absolutely. I think it's also important to point out that Exparel is not like profound anesthesia. So first of all, Exparel, like I'm going to butcher that exact quote, but once you open the bottle, I think it can only stay open for like 14 hours. You don't want to have any bacterial contamination. So I mean, we've opened an Exparel, bottle for a patient in the morning. We've got some left at the end of the day, and so like I didn't want to know what it feels like, so I'll go ahead and like inject myself like as a block. I wanted to see if I could block it for something, and so that was like good to know that it didn't create. I did a infraorbital block on myself, and so it didn't. It stayed numb for a good period of time, but it wasn't like that dense numbness that my face is fat feeling. Another story I had was it was a Friday morning case, third molar sedated. They called at like, 1 p.m., like, hey, we're still bleeding, or the suture came out, something to that extent. And it's Friday, so we're not messing around. I'm not coming in on a Saturday. So like, okay, come on back in, we'll take a look at it. And this kid, I was like, hey, we did Exparel, are you still numb? And I'm like poking around, and he's like, no, I'm not numb. Like he doesn't have that lip numbness anymore. And I'm like poking around. I was like, do you feel this? And he's like, no. And I was like, I put another stitch in and I didn't have to renumb him. And I was like, did you feel that at all? And he said, no, which just tells
wow.
me that like he is numb, but it's like an area, at the corner of his mouth that he doesn't have that profound feeling. His lip's not fat and he doesn't even know
Yeah.
he's numb, but I'm clearly able to, suture without, causing any pain or discomfort, or he's not flinching or anything like that. So it's like a very low grade numbness. So when we'll even get some people who are like, hey, I don't think this did anything. And I'd like to, counter that to be like, hey, you might not even notice that it did anything. But, the fact that you're not, calling me requiring narcotics, or you're not, you don't need anything more than the pain medication we prescribed is, I think, a pretty good sign.
Yeah, and just like you said, I think that is important to mention. Like, and I bring that up in the consultation because there's some people who will hear, "Oh, I'm numb for 3 days," and that's like a bad thing, right? They
Yeah.
picture their lip, their tongue, everything numb. It's just the worst feeling ever. And so you got to kind of say that to them. Okay, we're gonna numb it, but it's not that type of numbness. It's not very noticeable. It's inside of your cheek. It's not your lip and tongue. Yeah, I'm sure you kind of do the same thing, but it's just walking them through the process and kind of removing that fear that you're going to be with a numb tongue or something.
Yeah, no, exactly. And I usually tell them that, and I'm very descriptive when I'm with my hands when I'm doing my consultations. So I'm like, you might have some bleeding inside your mouth, and I like gesture to their mouth, and like for Exparel, like put my hands on the side of my cheek and say, we are going to put some long-lasting numbing. And I'm like, got my hands on the angle of my jaw there. That's going to last like only here, for 3 days. And so, people don't get horrified like you described, because it is. I mean, there's plenty of students or business people who have this idea, like, oh man, I've got presentations to do, or I'll be on phone calls, and you're saying I'm gonna be blubbering for, 3 days, and you'll be like, oh no, don't worry about it. It won't be like that.
Exactly. Well, good. Any other last minute type things on these topics?
No, I mean, so I guess the first time we had a centrifuge in our office was probably 2018. So it's kind of crazy to think that it's been, 8 years since we've been using it. I mean, we even get annoyed with carrying a centrifuge from room to room. So I've got 3 rooms and we've got 2 centrifuges, and I mean, I think it adds that much value that it's worth to have a backup one. I
For
think
sure.
when we only had one and when it was going down, or we having like a fuse was blown or something, like you said, it's like we're going back to what feels like the Stone Age, and it is going to be very different. And it does make you so much more grateful for what you do have when you do have it. But
Hmm.
it's one of these things that I find it valuable. We're doing it on so many of our patients. Yeah, and we're invested in it, to do that.
Great. Well, I think it helps me, it helps my listeners to hear someone like you that's been doing this for many years and just share some of the tips and experiences. Just really helps all of us improve our process and make things run smoother for our patients. So thanks for running through all that.
Absolutely. Thank you.
All right, Anish. Well, let's connect again at some point and do another episode. This is fantastic.
Yeah, absolutely. Yeah, you have a good weekend.
You too. Thanks so much.
Take care. Bye.
Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.